I would like to thank SBNS for allowing me to present today on the intraoperative mapping and monitoring of the optic pathways for intra-axial visual eloquent tumors during a sleep craniotomy. My name is Prajwal. I'll be presenting my data from King's College Hospital. So I'll be talking to you about different monitoring techniques that we have utilized in this study for the visual pathways and their impact in visual outcome in our prospective study here. Just talking about briefly on visual evoked potential. So we have utilized the standards mentioned here in this paper, where we have monitored the OZ, O1, and O2 as the scalp readings, as well as we are using the flash VEP recordings with the flash signals that go from the eyes with the electrodes. For an example of VEP mapping that has been done before in the past and which is commonly done, which have shown that there is good recordings that we can obtain even if the patient have an preoperative deficits. Despite that, a good recording. And in this example, where they have recorded a subcortical recording distant to the OR, a negative recording here. In the F image and the G image, there is a positive recording demonstrating a close proximity of the tumor to the optic radiation. In our study, we did a sleep craniotomies for these patients on 34 patients. The data was collected for 2 years, from 2018 to 2020. Where we obtained preoperative visual pathway tractography of the patients, as well as intraoperative data with scalp recordings from corkscrews electrodes, as well as direct cortical recordings with subdural strip electrodes and bipolar stimulation of optic radiation and primary visual cortex. So we correlated this data with extent of resection, surgical technique, and the visual outcome. So this picture is a snapshot of these different recordings. The picture A demonstrates VEP recordings with direct cortical strip electrodes, demonstrating the positive signals. The B image demonstrates VEP recordings with scalp recordings from the corkscrew scalp electrodes, and C and D are subcortical stimulation. First one with the direct cortical recordings with a positive signal here, and a scalp recording with bipolar stimulation. In our cohort, we had majority of the patients on the right side, around 79%, supratentorial lesions, and more so distributed equally among temporal lobe, parietal lobe, and the occipital lobe. And these are the example of the visual flash electrodes. We had preoperative patients with deficits on vision of homonymous hemianopia in 38%. One patient had Alice in Wonderland syndrome, and there was associated hemiparesis and seizures in 23% of patients. In terms of involvement with the optic radiation, the contrast enhancing component was involving the optic radiation in 64% of the patients, and the edema component, as per the FLAIR imaging, it involved the optic radiation in all the patients, 100% of the patients. We had majority of diffuse astrocytic tumors and oligodendroglial tumors, among which grade 4 glioblastoma was the majority. And we had metastatic lesions also, of which lung metastasis was the most common. On the extent of resection results, we had 91% gross total resection in parietal lobe lesions and 84% gross total resection in occipital lobe lesions. In these lesions, we were able to produce stable visual field outcomes post-operatively in patients, where 66% were stable in parietal lobe and 83% stable in occipital lobe. Among all the patients, out of 34, 21 patients had stable visual fields post-operatively, and 3 of them showed improvement in visual fields, and some of them deteriorated also. In terms of monitoring, we were able to monitor the visual pathways and VEPs with direct cortical recordings in 77% of occipital lobe lesions, 100% of scalp recordings, in 100% in temporal lobes, 100% in parietal lobes lesions. The stability of the recordings, if you look at the data, the 87% of the data was stable for scalp recordings in temporal lobe, but the DCR recordings were quite stable in occipital lobe readings. In terms of subcortical stimulation, we were able to produce good stability of recordings in parietal and occipital lobe lesions with 88 and 72%, which was significant. Thus, the results from our conclusion was that the occipital location was related with better visual outcome, and we were able to record different recordings depending on the location of the lesion, occipital for DCR. And the direct cortical recordings were better recorded with metastatic lesions and correlated with visual outcome. And this is an example of temporal visual eloquent tumor, which is in close proximity to the optic radiation, and we were able to record positive recordings as well as negative recordings on the subcortical stimulation. Similarly, this is a parietal eloquent tumor, which had positive as well as corticospinal tract recordings subcortically with the superimposed, you can see the red lines showing the superimposed CST and the yellow lines showing the superimposed optic radiation from the tactography, which correlated during the surgery, and positive recordings on the electrophysiology. Similarly, this was occipital lesion with close proximity to the optic radiation with the direct cortical recordings. We were able to demonstrate good VEP recordings over the calcarine fissure and a positive recording on the orange box. The black box demonstrated a drop in signal during operation that correlated with post-operative quadrantanopia in the inferior quadrant in the patient. Thus, in conclusion, we concluded that DCR recordings were reliable, and also the subcortical stimulation of the optic radiation were reliable techniques that can be utilized during a sleep craniotomy in patients with eloquent tumors. The DCR was specific for 100% of the patients. And these are all my slides. Thank you very much. And I would like to welcome any questions. I'll play the video while we answer the questions.